One is that diet in any form of kidney disease should be individualized. So this I've learned from one of my teachers, where they say that if the patient isn't eating anything, then there's no sense of dietary restrictions. Just let him eat. And the other thing I would like to point out is we all know what is to be done, but how it has to be done, you are going to need to consult your friendly hospital dietitian, because proteins, calories, magnesium, sodium, potassium, calcium, oxalate, these are all terms and numbers being thrown across. But which food has how much, I am sure, except for the dietitian, nobody can uh, help you with that. So to get to the first slide. So kidney stones, it's a very common problem faced on a day-to-day basis by not only family physicians, but also by urologists, nephrologists, MD medicine. And the most commonly thing which we ignore is the diet in kidney stones. So a 34-year-old male presented with recurrent kidney stones and a family history of kidney stones. On evaluation, he was found to have hypocitrituria. Now, what dietary advice would you suggest and why? So one thing to remember is that kidney stones are of various kinds. You could have calcium oxalate, calcium phosphate, uric acid stones. There are other various causes, genetic causes of kidney stones. The causes could be low citrate in your urine. They could be the cause could be high calcium in your urine. So one diet does not fit all. So you got to evaluate what is the cause of the kidney stone before you can prescribe a diet. But there are certain rules which can apply. Now, why do you need to give a prevention in kidney stones? Because 50% will have another stone at 10 years and 80% will have a recurrence at 20 years. So without dietary restrictions or dietary modifications, the recurrence risk is very high. And patients with recurrent kidney stone disease often have obesity, diabetes, hypertension, and coronary artery disease. As you can see, this is basically the spectrum of metabolic syndrome. The main thing, the rule of thumb is that they got to make urine of about 2.5 to 3 liters a day. Now, that is what is important. More than and this fluid need not always be water. The misconception is that it has to be always been water. There are studies which have showed that milk, coffee, and other fluids in moderation can compensate for just fluid which is taken. Now, some people will find this difficult, elderly gentlemen who have a benign prostatic hypertrophy, or if you're a cab driver and you ask him to drink 3 liters of water, so in Mumbai, it's impossible for the poor man to find a bathroom. So this is another problem which is there when you advise fluids to renal stone patients. Weight loss and exercise, that's a very important thing. Like I specified, that metabolic syndrome is actually contributing to renal stone disease. So one needs to basically lose weight and exercise. And that's another thing which Dr. Arun Shah sir was mentioning about in all his things, in chronic kidney disease as well. In hemodialysis patients, there are a lot of studies which are showing now that actually exercise is very beneficial. So apart from diet, the other thing is lifestyle modification is exercise. Now, there's a diet known as the Borghi diet, a diet that reduces urinary stones. So compared with the typically recommended low calcium, low oxalate diet to the Borghi diet, which had decreased the sodium, low animal protein, and low oxalate with non-restricted calcium, actually this diet was found to be more beneficial. So, we are always told that you reduce your calcium in the diet if you're having kidney stones. Actually, it does not hold true. The calcium in the diet actually binds to the oxalate, which then prevents the oxalate from getting excreted in the urine and therefore prevents the formation of calcium oxalate stones. Now, vitamin C. Now, this with the COVID pandemic, everybody has been told that you got to take industrial doses of vitamin C. And unfortunately, we had a patient recently at the place where I practice at Global Hospital, and Dr. Bharat Shah sir was actually involved in the treatment of his care. And we found that due to mega doses of vitamin C, this gentleman developed a crystal nephropathy. And vitamin C is known to cause urinary stones. So actually, it is more pronounced in men than in women, and the risk would increase significantly if your vitamin C intake is more than 700 to 800 milligrams per day. So in a patient who is at risk of forming kidney stones, or who has had past history of kidney stones, and especially in a male, it would be ill-advised to give large doses of vitamin C. Anything below 500 milligrams should be okay, but anything above that should be avoided. Now, what is the rule of thumb in kidney stones? Like I said, everything should be individualized. But if you have to give a broad guideline, it would be weight loss and exercise, a low sodium diet, a low animal protein diet, not high dietary calcium intake. And by this, I do not mean that you take calcium supplements, but a good calcium intake in your diet. High oxalate foods are delicious and nutritious, but not as supposed to be avoided in patients who are forming oxalate stones. And if you need to take them, then you need to combine them with calcium in your diet. The other common problem that we see in day-to-day practice is nephrotic syndrome, which is actually seen in young children. So this was an 8-year-old male who presented with generalized body swelling, and on evaluation was found to have nephrotic range proteinuria, hypoalbuminemia, and dyslipidemia. The GFR was normal, and he was started on steroids. Now, this case was taken because of the simple reason that any edematous patient, we ask them to restrict their fluid, but it is actually more important to restrict their salt intake, because it is the salt intake which will actually help in getting rid of the edema more than the fluid restriction. So there are no food items or changes in the diets that are known to cause nephrotic syndrome or relapses. And this is at a very tender age of 8 years, where they are very prone to have growth retardation if you don't feed them well. So one has to ensure that a child with nephrotic syndrome is on a healthy diet. A no added salt diet is advised during the periods of active disease. So this is where what Sir said, that anything that is packed, like pickles, salted chips, savory snacks, and all of these are packed. So when you have an acute active illness, one should avoid added salt in the diet. An adequate intake of protein. These young children are losing protein in the urine. So if you restrict their protein, they'll get more hypoalbuminemic and predispose themselves to malnutrition and infections. So one needs to basically make sure that they have an adequate protein intake in their diet. Fluid restriction is not advised. Remember that the treatment of nephrotic syndrome is steroids, and it is a tendency to gain weight. So again, your exercise and a diet rich in fruits and vegetables should be encouraged. And junk food obviously should be avoided across the board, and definitely should be avoided in nephrotic syndrome. Dr. Arun Shah sir has actually covered acute kidney injury in great detail, and I'm not going to go through the entire part of it, just a few pointers here. So what do you see at a family physician level? A 45-year-old male presents with high-grade fever and is diagnosed to have malaria. On evaluation, he is found to have a serum creatinine of 2 and a serum potassium of 5.5. His previous renal function was normal. What dietary advice would you suggest? Now, this is a very common scenario. You will get somebody who walks into your clinic who's had malaria, either falciparum or vivax. Either he's taken some NSAIDs, or the malaria itself has caused a bump in the creatinine, which has gone from maybe 1 to 2, and the potassium has gone high. Now, you need to keep these patients well hydrated. But this is a case where you would tell them to avoid stuff like coconut water and fruit juices, and fruits which are rich in potassium. So you don't want this potassium to start creeping up. So here is where the dietary advice is on an OPD basis. This has been extensively covered by Arun Shah sir about the protein intake. And basically on an OPD basis, these patients with malaria, typhoid, dengue, chikungunya, who are nauseous and are not eating well, I would suggest you just liberalize their diet, as long as, and if their potassium is under control, nothing much needs to be done. If their potassium is high, then you can still liberalize their diet, but keep them on a low potassium diet, which our dietary friends would be helpful in advising us further. Now, what else have you to see in acute kidney injury on an OPD basis? Remember, you also have to look at the fluid balance. So on an OPD basis, if a patient comes to you and he cannot monitor his urine output at home, the best thing to do would be to do a daily weight. And that weight will tell you whether he's retaining fluid every day. And in acute kidney injury, the main thing on an OPD basis you've got to monitor is serum electrolytes. So if you see an uptrend in the potassium, or a downtrend in the sodium, or the uptrend in the creatinine, then it would be best to refer to a nephrologist. Now, the other thing one has to remember is that when you're recovering from acute kidney injury, there will be a good amount of urine which will be passed. That is known as the diuretic phase of acute tubular injury. And at this time, the patient will lose a lot of potassium in the urine. So the hyperkalemia may swing to hypokalemia if you restrict a large amount of potassium in the diet. So one has to make sure that you do not restrict it so much that the patient goes that. This can especially happen in patients with obstructive uropathy. Like if a patient has a benign prostatic hypertrophy and you put in a Foley's catheter, and initially the potassium will be 6, but as the kidney function starts improving, that potassium goes from 6 to 3, and then the patient can get an arrhythmia. So one has to be aware that the hyperkalemia will also improve very quickly once the underlying cause of the acute kidney injury is treated. Apart from that, sir has covered most of these points, so I'm not going to go into them in detail. Now, this is a favorite topic of everybody's, and it's kidney transplant. And Dr. Arun Shah sir had made a few points regarding this. You remember when he told you that when you are not on dialysis and your chronic kidney disease, you forget that once you are on dialysis, you need to increase your nutritional intake. A very similar thing happens also in kidney transplant. So a 36-year-old female whose weight was 40 kgs and height was 5.53 feet, undergoes a living donor kidney transplant. She had good graft function on day 7 post-op, no hyperglycemia. What would be your dietary advice be? I would like to point out a few things here. This lady was a preemptive transplant. So in that sense, we do about 25% of our transplants are preemptive. That means that we do not put them on dialysis at all. Once they get to end stage kidney disease, they go straight for kidney transplant. And I think according to us, as per the data in India, this is the highest number at global hospital where we do preemptive transplants. Now, the difference here is that the patient does not have to undergo the agony and the suffering of dialysis, but here one has to ensure that these patients are told to be on a low protein, low potassium diet, low phosphorus diet. And once they are transplanted and the kidney function returns to normal, then it is very important that they get a good nutrition, high protein nutrition, so that they are not prone to infections. But what are the other points that one has to remember? Factors that lead to foodborne illnesses. Now, remember, when you get a kidney transplant, you're on immunosuppressive drugs like tacrolimus, mycophenolate, mofetil, and steroids in the form of prednisolone. These compromise your immune system. So raw, unpasteurized milk is definitely a source which should not be done. And one has to remember this. There is this trend in our hinterlands, where they believe that if you drink the milk right out of the cow, it is much healthier. But this is unpasteurized milk, and this will increase the risk of getting zoonotic infections. The other thing is that drinking water. So the water has to be filtered and then has to be boiled, which are all day-to-day points which you have to tell your patients on a basis. So if you do not want waterborne infections like Giardia, Yersinia, Cryptosporidium, then or activities, like from swimming, then one has to be careful about these things. You have to heat the food at the right temperature for the right sort of food that is. So as you can see, the temperatures vary according to the food. So if it is meat, it is a different temperature. If it is eggs, it's a different temperature. If you want to get rid of all the bacteria and the other foodborne infections, one has to make sure that the food is hot. And this is where we advise our patients to eat fresh food, which is cooked. You normally tend to advise them to avoid raw foods. And the other thing one has to make sure is like look at the left side and look at the right side of the screen, and you will see there's something known as cross contamination. So don't mix your vegetables with your poultry. This is another thing which will actually lead to cross contamination and lead to GI infections. So the take home message in transplant is that you eat fresh food, you eat it when it's well cooked. You have to increase your protein intake, you have to increase your nutrient intake, your phosphorus will go down post transplant. So as long as it is a healthy cooked food, the dietary restrictions after transplant are almost nil, and you can go back to leading a healthy lifestyle. Thank you.